What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about neuroanatomy. We talked about the pyramidal tracts and the extrapyramidal tracts, upper motor neuron lesion, lower motor neuron lesion. We talked about strokes. We talked about neurogenic shock and other types of shock. We talked about Duchenne muscular dystrophy and Becker's muscular dystrophy. We talked about Lambert-Eaton myasthenic syndrome and myasthenia gravis. We talked about multiple sclerosis and Guillain-Barré syndrome. We also talked about the Glasgow-Coma scale, brain herniation, and intracranial hypertension. Today, we shall talk about a cause of intracranial hypertension, and that is hydrocephalus. Hydro means water. In this case, it means fluid, as in hydrodynamics. And cephalo means what? It means your head. So hydrocephalus is a medical condition where we have too much cerebrospinal fluid in your head. Click the like button, click the subscribe button, and let's get started. I have two playlists on this matter. One is for neuroanatomy, and the other is for everything. It has anatomy, it has physiology, it has pharmacology, it has pathology, and internal medicine. Watch them in order if you really want to up your game. This is your brain as seen from the outside. This is the lateral aspect of the cerebrum. But if we look on the inside, we will see ventricles. You have two lateral ventricles and then a third ventricle, a cerebral aqueduct of Sylvius, a fourth ventricle. And after the fourth ventricle, you have two options. You can continue within the central canal of the spinal cord, or you can escape the fourth ventricle through the foramen of Meninges and two foramina of Luschke, and you will go into the subarachnoid space to surround the brain and to surround the spinal cord. Where did the cerebrospinal fluid come from? It came from the blood. Really? Yeah, it came from the capillaries. What kind of capillaries? They are the capillaries of the choroid plexus, which line and invade the ventricles, especially the lateral ventricles. The choroid plexus is lined by ependymal cells, which are neuroglial cells that secrete cerebrospinal fluid. So this is to answer the question, who made the cerebrospinal fluid? Okay, but who's gonna drain the cerebrospinal fluid? And the answer is a bunch of arachnoid granulations, which will drain the cerebrospinal fluid from the subarachnoid space to big veins known as dural venous sinuses, such as the superior sagittal sinus. If you want to see more videos like this in the future, drop a brain emoji in the comments. Remember that you have telencephalon, diencephalon, mesencephalon or midbrain, and rhombencephalon. Each one of them has a cavity. What's the name of the cavity of the telencephalon? These are the lateral ventricles. What's the name of the cavity of the diencephalon? This is the third ventricle. What's the name of the cavity of the mesencephalon? It's not a ventricle, but it's a cerebral aqueduct of Sylvius. What's the name of the cavity of the rhombencephalon? It is the fourth ventricle. Between the lateral ventricles and the third ventricle, we have two foramina of Monro. Between the third ventricle and the fourth ventricle, we have the cerebral aqueduct of Sylvius. Ancient Rome was famous for its aqueducts, and so is your brain. That's a historic dad joke. So, the cerebrospinal fluid is made by the choroid plexus, which has ependymal cells, and these invade the ventricles and they make cerebrospinal fluid into the ventricles. Cerebrospinal fluid will pass from the lateral ventricles into the third ventricle through the interventricular foramina of Monro. Then I am in the third ventricle now. I will pass from the third ventricle to the fourth ventricle via the cerebral aqueduct of Sylvius. After the fourth ventricle, I have two options. You can continue straight ahead downwards to be inside the central canal of the spinal cord, or you can escape this central canal of the spinal cord by going outwards. You can escape in the midline by the foramen of Monro. Monro is one in the midline, and you can escape laterally, right and left, by the two foramina of Luschke. Luschke is lateral. After that, you are now in the subarachnoid space, which is under the arachnoid but above the pia mater. And then you will surround the brain and surround the spinal cord. By the way, if you want an anatomy review like this, go to my anatomy playlist. I have 2 review videos for each topic in anatomy. So there are 2 videos for the head, 2 videos for the neck, 2 for the thorax, 2 for the abdomen, 2 for the pelvis and perineum, 2 for neuroanatomy, 2 for embryology, and of course the extremities. After all of this, who's going to drain the cerebrospinal fluid? Arachnoid granulations. They will drain the cerebrospinal fluid that's in the subarachnoid space, which came from the cerebrospinal fluid of the ventricles, which came from the ependymal cells that line the choroid plexus that invaded the ventricles. Now we are in the arachnoid granulations. We're going to drain the CSF from the subarachnoid space into dural venous sinuses, such as this doozy superior sagittal sinus. If you follow the superior sagittal sinus, it will become the right transverse sinus, which will become the right sigmoid sinus, which will become the right internal jugular vein. The right internal jugular vein will join forces with the right subclavian vein to give me the right brachiocephalic vein. Then, brachiocephalic vein on the right with brachiocephalic vein on the left will unite together to give me the superior vena cava, which will end up in the right atrium of your heart. By the way, there is a very important topic known as the subarachnoid cistern, and you can learn about this topic by watching my video titled Cerebrospinal Fluid, which you can find in my neuroanatomy playlist. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. Do you see this red right here? This is choroid plexus, which is lined by ependymal cells, which make cerebrospinal fluid. What's the name of this ventricle? These are the two lateral ventricles. Here is one of those lateral ventricles. It has an anterior horn, a body, posterior horn, inferior horn. Then the lateral ventricle, through the interventricular foramen of Monro, will pass the CSF from the lateral ventricle to the third ventricle. The third ventricle, via the cerebral aqueduct of Sylvius, will give its cerebrospinal fluid to the fourth ventricle. Then after the fourth ventricle, you can continue downstairs in the central canal of the spinal cord, or you can escape via the foramen of Megendie or the two foramen of Luschka to be in the subarachnoid space. Now, what if I have an obstruction here in the cerebral aqueduct of Sylvius? What's going to happen? Well, the cerebrospinal fluid will pile up in the third ventricle and then back up into the lateral ventricles. So I'll have more cerebrospinal fluid proximal to the obstruction, meaning the third ventricle will be swollen and the lateral ventricles will be so big. It's called ventriculomegaly. However, what's going to happen to the poor fourth ventricle? It's not receiving any CSF, so it will shrink in size. If you do an MRI, you will find that the fourth ventricle is so tiny, but the third and the lateral ventricles are huge. We've talked about the intracranial pressure and intracranial hypertension in previous videos. Today we'll review them quickly. Pressure is force over area. There is pressure inside your skull, called intracranial pressure. The force is the force of the cerebrospinal fluid and others, but just let's focus on the CSF. If I have more CSF than normal, this is hydrocephalus by the way, what do you think is going to happen to the pressure? The pressure is going to be high. So this is called elevated intracranial pressure or intracranial hypertension. How can we measure the intracranial pressure? Well, since the subarachnoid space surrounds the brain and the spinal cord, you can assess the CSF pressure by digging into the subarachnoid space beneath the spinal cord. Via lumbar puncture, connect your needle to a manometer to measure the pressure. Whatever you're measuring right here in the lumbar CSF is roughly equal to the intracranial pressure. Unless there is an obstruction, because if there is an obstruction somewhere, for example in the cerebral aqueduct of Sylvius or the interventricular foramen of Monro, etc., the pressures might differ upstairs from downstairs. What is the normal intracranial pressure? In the human adult, it should be less than 15 millimeters of mercury while supine. So it's about 7 to 13 millimeters of mercury. And since the density of mercury is 13.6 times greater than that of water, if you want to convert millimeters of mercury to millimeters of water, simply multiply by 13.6. Multiply the 7 by 13.6, you get something close to 100. Multiply the 13 by 13.6, you get something closer to 180. So this is roughly accurate. Next, what is the Monroe-Kellie hypothesis? It goes something like this. Your skull is like a box that is 100% full, packed, stacked, and stuffed. There is not a single inch of empty space in your skull. So therefore, anything abnormal that will appear, for example, a brain tumor or excessive cerebrospinal fluid production or decreased cerebrospinal fluid absorption, what's going to happen is that the pressure has to rise. Or your skull has to expand if you are a newborn, or something from within your brain has to give up and bulge outwards, and we call this herniation. And if that was not bad enough, consider the effect of the high intracranial pressure on the poor arteries that are trying to supply the brain. Look at this. For example, let's say that this is the vertebral artery trying to supply the brain. If I have very high intracranial pressure, what do you think is going to happen? I'm going to press on the vertebral, press on the vertebral, press on the vertebral until the poor vertebral gets squeezed and smothered and suffocated. And this will decrease the perfusion pressure that's going to the brain. So this decreases cerebral perfusion pressure, which can lead to ischemia and hypoxia in the brain. Hashtag ischemic stroke. What's the difference between transient ischemic attack and stroke? Transient ischemic attack is ischemia, but a stroke is an infarction. The former is a cell injury, but the latter is cell death. Cell injury could be reversible, but cell death is irreversible. So how can I rule out the presence of obstruction? How can I make sure that the pressure in the intracranial cavity is the exact same thing as the pressure in the lumbar puncture? To rule out obstruction, you can use the Queckenstedt test. Remember that the superior sagittal sinus eventually ended up in the internal jugular vein. So the test goes like this. If you compress the jugulars, what do you think is going to happen? Well, the pressure will build up in all of these veins, and then the pressure will build up in these arachnoid granulations, and then the pressure will increase in the subarachnoid space, and then the pressure will increase in the CSF and the ventricle, and of course the subarachnoid space surrounds the brain and the spinal cord, so the pressure will increase at the lumbar puncture. So when you compress the patient's jugulars, you will find that the manometer is giving you higher pressure. Oh, you compress, the pressure goes up, and then you remove your compression or decompress, the pressure decreases. If you find this ding-dong action, it means that this person has no obstruction, which is good. Intracranial pressure. What causes intracranial hypertension? Here are the causes, here are the consequences. Causes of increased intracranial pressure include idiopathic intracranial hypertension, which is the topic of another video in my neurology playlist. Brain abscess can raise the intracranial pressure. Hematoma inside the cranium can raise intracranial pressure. Brain tumor aneurysm inside the cranium can raise the intracranial pressure. All of these are what? Space-occupying lesions. Hydrocephalus, which is today's topic, can raise the intracranial pressure. Metabolic disorders like hepatic encephalopathy and hyponatremia can raise the intracranial pressure. Epilepsy and seizures can raise the intracranial pressure. Remember that sodium problems equals CNS problems. Okay, now my intracranial pressure is high. What's going to happen to me? If I'm an infant, my skull sutures have not fused yet, so therefore my skull will grow bigger and bigger and bigger, and this is macrocephaly. You can use your search engine to search for a picture of a newborn with hydrocephalus, and you will see exactly what I mean. Headache, not any type of headache. It is frontal headache, not any type of frontal headache. It gets worse when I lean forwards. It gets worse in the morning. Vomiting, not any ordinary vomiting, but projectile vomiting that can reach the ceiling. I'm exaggerating, of course. Papilledema, which can lead to blurry vision. Increased opening pressure on lumbar puncture. Abducens nerve palsy, which is palsy of the 6th cranial nerve. I'm gonna tell you why soon. Altered consciousness, abnormal gait, midline shift on neuroimaging, brain herniation can happen, and if the increased intracranial pressure pressed on the brainstem, I will get the Cushing triad or the Cushing reflex, which is a triad of hypertension, bradycardia, and irregular breathing. Increased intracranial pressure can also lead to hypoxic or ischemic injury, especially if there is herniation. So here are the types of hydrocephalus. We have non-communicating hydrocephalus, we have communicating hydrocephalus, we have normal pressure hydrocephalus, or NPH for short, and we have hydrocephalus ex vaccuo, also known as hydrocephalus with ventriculomegaly, because the ventricles are huge. So what is true in all of these conditions? What's true is that there is increased CSF inside the ventricles, which increases the size of the ventricles. However, not all of them will have increased intracranial pressure. Many of them will have high pressure. Some of them will have normal intracranial pressure. How can we diagnose all of them? If we're talking about a neonate, especially a very young neonate, we try not to do CT scan. So we'll go for ultrasound. But if we're talking about an adult like yourself, we can use MRI, we can use CT scan, and we can use lumbar puncture. Let's start with non-communicating hydrocephalus. What's happening? First of all, why do you call it non-communicating? Because there has to be an obstruction. Let's say that I have an obstruction in the cerebral aqueduct of Sylvius. Therefore, now there is no communication between the third ventricle and the fourth ventricle. That's why it's called non-communicating hydrocephalus. This will decrease CSF passage from the ventricles to the subarachnoid space eventually. Of course, the intracranial pressure will be elevated and the patient can suffer from macrocephaly if we're talking about an infant, morning frontal headache, projectile vomiting, papilledema, Cushing reflex, abnormal gait, altered consciousness, Abducens nerve palsy, and more. How about communicating hydrocephalus? Well. I cannot find an obstruction that I can detect. So how come the patient has hydrocephalus if there is no obstruction? Maybe because the patient is making more CSF than normal, or maybe because the patient is draining less CSF than normal. It's increased inflow but decreased outflow. The clinical findings are very similar. Next, normal pressure hydrocephalus. What's going on? Decreased CSF absorption. It's a clinical triad of what? Wet, wobbly, and wacky. It's the 3 W's. What do you mean by wet? I mean urinary incontinence. What do you mean by wobbly? I mean ataxia. Remember, abnormal gait is a feature of hydrocephalus. And what do you mean by wacky? Dementia, memory loss. Next, hydrocephalus ex vaccuo. What is going on? I have brain atrophy. Why? Maybe because I have Alzheimer's dementia. Maybe because I have Pick's disease or frontotemporal dementia. Or maybe because I'm a chronic alcoholic. All of these can lead to atrophy of the brain tissue. And if the brain substance is shrinking, but the skull volume has to remain constant because you are an adult, and therefore your sutures have fused. So therefore, if the brain tissue is shrinking, something has to replace it. So therefore, you end up with increasing ventricular size. If the neurons are dying, the cavities will expand. That's how physics works. So these patients have ventriculomegaly on neuroimaging. How can we treat these patients? Correct the underlying cause. If there is an obstruction, you need to relieve that obstruction, sometimes surgically. But how can we lower the intracranial pressure in general? Sing with me. Head elevation, hyperventilation, and then the double D's. Diuretics, dexamethasone. What is dexamethasone? It's a steroid, so the next is shunt. Head elevation, hyperventilation, diuretics, dexamethasone, and shunts. Let's go one by one. Why head elevation? Because when you elevate the head, gravity takes its toll to try to bring the fluid away from your brain and towards anything else, which will decrease your intracranial pressure. Next, hyperventilation. Why is this? Now here is a nice physiology lesson. There are 3 things that your brain hates more than anything else. Hypoxia, hypercapnia, acidosis. Hypoxia, hypercapnia, acidosis. What is hypoxia? Low oxygen. What is hypercapnia? High carbon dioxide. And what is acidosis? High protons, which will lead to a low pH. Hypoxia, hypercapnia, acidosis are very dangerous for your brain. So if the brain has hypoxia or hypercapnia or acidosis, guess what the brain will do in order to try to save itself? It will dilate the vessels that are going to the brain. And when you dilate the vessels that are going to the brain, the flow, not the speed, but the flow of blood to the brain goes up, hopefully bringing more oxygenated blood to the brain to save the day. So hypercapnia causes increased cerebral perfusion. Therefore, we can say that conversely, hypocapnia will decrease cerebral perfusion. And if there is less blood going to the brain, there will be less intracranial pressure. Next, diuretics. Why is this? I mean, think about it. The intracranial pressure is just like your blood pressure. What does that mean? If you increase the volume of fluid, the pressure goes up. But if you decrease the volume of fluid, the fluid decreases. And remember that your cerebrospinal fluid originated from the blood via the choroid plexus, remember? So therefore, if you can take some of the fluid away from my body, the CSF will decrease its pressure. Such as mannitol and hypertonic saline, these are osmotic loads. They are osmotically heavy and they pull water after them. And in the kidney, they will be excreted, taking a lot of water with them, and that's why they are diuretics. Acetazolamide can help as well. To learn more about acetazolamide, check out my pharmacology playlist, and you will learn about diuretics as well. Next, dexamethasone. Why is this? Because dexamethasone is a steroid, and dexamethasone is anti-inflammatory. Why should I care? Because inflammation dictates vasodilation. Inflammation equals vasodilation. Therefore, anti-inflammatory equals what? Vasoconstriction, which will reduce the amount of blood going to your brain. And of course, why exactly we use steroids here is poorly understood. But remember my song, when doctors do not know what to do, they give steroids to you. And in most cases, they work like magic. I mean, if you are a doofus doctor and have no idea what's going on, if you keep alternating between corticosteroids and antibiotics, you have no idea how many diseases you can treat. But I do not recommend this, of course. You better learn and understand what's going on. Next, shunts. Oh, this is like a surgical intervention. Why? If the pressure builds up in my brain, what should I do? Shunt it. Take the CSF away from the brain and towards something else. So, remember that the CSF around the brain is the same CSF around the spinal cord. So we can shunt the spinal cord to the peritoneal cavity, so that the cerebrospinal fluid can escape the subarachnoid space and go to the peritoneal cavity, which is a huge cavity that can handle the truth. That can handle the pressure. Or, and this will not make you sleep tonight, optic nerve fenestration. What in the world is this? Remember that the eye is part of the CNS. The optic nerve is part of the CNS. Here is the eye, okay? The pressure is too much in the CSF, around the brain. Remember that the subarachnoid space also exists around the optic nerve. So, if a surgeon can open optic nerve fenestrations, guess what's going to happen? You're going to relieve that pressure. The CSF will escape through the optic nerve or the coverings of the optic nerve, and then the veins around the eye will drain the cerebrospinal fluid away and back to the heart. Mad respect to the doctors who can perform such procedures. But I am not letting anybody fenestrating my optic nerve. They can curse me, they can torture me, they can persecute me. But there is one thing that they can never take away from me: my Gray's Anatomy textbook. Now, we said that intracranial hypertension can affect the abducens nerve. But why the abducens nerve? We have 12 cranial nerves. Why do you pick the abducens? If you have watched my neuroanatomy playlist, you will remember that in the video on the abducens nerve, we have said the following. The abducens nerve, or cranial nerve number 6, has a long course in the subarachnoid space. I did not say that the abducens nerve is the longest nerve. I did not say that. I just said within the CSF space, the course of the abducens is so long, so it can be affected and squeezed and suffocated by intracranial hypertension. And that's why in diseases such as idiopathic intracranial hypertension or pseudotumor cerebri, the abducens nerve can be affected. Normally, the abducens nerve, may he rest in peace, used to be able to contract the lateral rectus and make your eye look lateral. Look outwards towards your temple. But if I lose the abducens nerve, then the ipsilateral eye will look medially instead, towards your nose. And we call this medial strabismus. Don't forget to check out my idiopathic intracranial hypertension video, my intracranial hypertension video, and my brain herniation video. Do you want to learn about opioids, anesthetics, stimulants, sedatives and hypnotics, anti-epileptics, antidepressants, antipsychotics, and anti-Parkinsonian medications? Then download my neuropharmacology course at medicosisperfectionalis.com. It comes with videos, notes, and cases. To learn about the adrenergics, the cholinergics, the nicotinics, the muscarinics, the alphas, the betas, etc., download my autonomic pharmacology course at medicosisperfectionalis.com. To learn about strokes, to learn about myocardial infarction, to learn about cardiac arrhythmias, ARDS, acute limb ischemia, drowning, and toxidromes, download my emergency medicine high yields course at medicosisperfectionalis.com. Help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses. notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.